Hi, this is Brian Kim. I'm going to share with you case number 268 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can refine and hone your technique and provide the very best for your patient. So this patient has a giant pupil, soft lens, and you're going to see really great anatomy to teach double chop and cross chop. And I'm going to share with you step by step how I'm able to achieve easy lens disassembly using double chop and cross chop and fracturing the lens into 3 pieces within literally 3 seconds. And then I'm going to place a Panoptix Toric lens and place it at the 85-degree axis. So you can see this is the eye. You can see the corneal marks that I made in the pre-op area. You see nice and distinct marks with the way I do this. If you want to know how I make those marks, you can try to find my video in my YouTube library. Use a corneal marker, which will help me to center and size the rexus. You can see this is the left eye. There's a little bit of Bell's reflex. And make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium. I'm using the cannula to twist within the incision for the Orlock technique so I can turn the eye down. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I enter. These are the sharp tip Morio microrexus forceps. I puncture the center, pull down towards me, grabbing the right side of the tear, following the outline of the corneal mark that I made before. You can see that it's a small profile rexus forceps, and the teeth open nice and wide, so I'm not struggling to grab the rexus edge. You can see this patient's turning the eye quite a bit, so I lost grip with the cannula. But because I'm not grabbing the eye, I don't cause any scratches, and I'm not causing any corneal abrasions or conjunctival hemorrhages. You can see if I feel like the chamber is collapsing, I can push more dispersive viscoelastic simultaneously as I hold the eye with the Orlock technique. Finish off the rexus. Burp some viscoelastic out, coating the corneal surface with the viscoelastic so my assistant doesn't have to worry about wetting the eye anymore. And this is the capsule fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, give a little bit of a wiggle, push the BSS and get a nice wave, lift the lens up with the cannula, and then decompressing the bag, pushing the lens back in, sweeping and pushing BSS on the left side and then the right side, loosening up the lens. Because this is a soft lens, I'm not going to try to aggressively turn the lens because the lens is already soft and it's probably just going to cheese wire anyway. Lifting the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Lifting the iris up to prevent reverse pupillary block. Removing the surface epinuchal material. You can see I'm pronating my hand. I'm leading with the chopper tip. The chopper tip is pointed down. And by doing it this way, I can slide the chopper under the rexus edge and placing it into the capsular fornix. I keep that leading edge of the chopper down. So I'm definitely within the bag. I turn the chopper vertically. Now I'm hooking the peripheral lens with the chopper. I'm definitely down at the equatorial level in the same horizontal plane as the densest part of the lens. Now you see I'm turning the phaco tip vertically, subincisionally. By doing it this way, I'm able to flank the lens on either side. Because the lens material is soft, I'm able to bring the instruments together and fracture the lens completely in half. Again, because the lens material is soft in the epinuclear area, with the chopper on the other side and the phaco tip proximally, I'm able to flank the lens, push the instruments deep into the lens material at the same level of the endonucleus, and I'm able to fracture the lens. I'm sliding the chopper under the right heminucleus. You can see I'm pronating my hand, making sure that the chopper is nice and flat. I'm sliding it under the rexus edge. Again, I'm gliding it over the endonuclear surface, and as I go out to the periphery, it's definitely underneath the rexus edge. Once I get out to the periphery, Again, I turn my chopper so it's vertical. I've hooked the lens from the periphery. You can see the phaco tip is deep between the heminuclei. The chopper is now vertical, hooking the peripheral lens around the right heminucleus. And as I pull the chopper centrally, because the phaco tip is in the middle, I'm able to chop the lens against the phaco tip, and the phaco tip is acting like a chopping block. Using some vacuum to lift that first quadrant up, you can see it's a rather soft lens, and I'm able to remove that piece rather easily. Trying to turn the lens a little bit with the chopper, getting around the endonucleus, hooking the endonucleus and popping it up. You can see there's distinct delineation between the endonucleus and the epinucleus, and in this situation I was able to hook the endonucleus with the chopper and pop it up out of the bag. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip and fracturing the heminucleus in half. And then the rest of this is using the chopper as well as the vacuum to just remove each of the quadrants. And then finally removing the epinucleus. I like to remove the epinucleus and keep the cortex intact. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the irony handpiece. I always start sub-incisionally, peeling from anterior to posterior. Why do I like to keep the cortex intact? Because I want to be able to peel the cortex from anterior to posterior. If I don't peel it from anterior to posterior and I just grab it from posterior and just yank it out, you're going to have a lot of that fine cortical wisps, which is rather annoying. And the more lens material you leave in the eye, the more you have to try to clean up and the more stubborn it is. And if you don't get all of that cortical material out of the bag, later on down the road, it can turn into a large Sommering's ring. And that retained lens material, even though it doesn't seem like it's a lot, it could end up being a lot down the road. So I did the best I could, peeling the cortex from anterior to posterior. Switching to polish mode, polishing under the rexus edge, and trying to peel off the fine cortical remnants that I have there. You can see this beautiful big pupil really illustrates very well the positioning of the phaco tip and the chopper when I perform the double chop and cross chop techniques. Using mechanical fracturing techniques in this type of soft lens. Trying to sculpt the lens like this would be absolutely makes no sense. When you try to sculpt a soft lens, it just kind of falls apart and then you can't crack it. And then you're going to get that endonuclear bowl, which is really hard to remove. And then people go after the endonucleus with high vacuum towards the posterior capsule, which is really a bad idea, a really bad technique. And this technique completely bypasses those concerns and risks. Pulsing BSS into the subincisional capsule fornix, you can see there's a lot of stuff coming out. And that is because, again, the cortex, when I tried to peel it off, didn't really peel from anterior to posterior 360 degrees. So I have some remnant of cortical material. Turning off infusion and pushing cohesive viscoelastic to fill the bag. Polishing under the rexus edge. Removing the lens epithelial cells and trying to remove any fine cortical material. You can see some more cortical material coming out from the subincisional area. I recall some people saying you don't want to polish when you're putting a toric lens in because they state that somehow polishing makes the lens turn more. I've never seen that to be the case. I've never found that to be the case. I don't really struggle with poor axis positioning when I do cataract surgery. I've done the markings and the way I do it the same exact way every time. I've never felt like I've needed any other type of device to get better accuracy and precision when I place the lens on axis. But certainly there are many ways to do it. I'm just saying that I haven't really had problems with the lens rotating, and I don't really believe polishing or not polishing has any bearing on the positioning of the toric axis. Placing the single piece acrylic lens into the capsular bag. Polishing under the rexus edge. I want to place this lens at 85 degrees. I'm removing the viscoelastic from the anterior chamber. Once I have all the viscoelastic out of the eye, that's when I start to do the positioning. It makes no sense to position the lens when the viscoelastic is still in the eye, because when you take the viscoelastic out, guess what? It can turn the lens. So there's no sense in focusing on the positioning until you get all the viscoelastic out. So I'm placing the marker, placing the axis marker on the eye, and I actually have to turn it about 10 degrees clockwise. And remember, you can always turn the eye either clockwise or counterclockwise. It doesn't really matter which direction, as long as you have infusion on. And so that's the most important pearl. And it makes sense, but I still see people trying to push the lens with OVD in the eye. It makes no sense. Again, why? Yeah, you're filling the eye with OVD and you're able to turn it. But remember, you have to take that OVD out. And if you take the OVD out, it's going to change your lens position. Again, as the viscoelastic comes out of the bag, the lens can start to turn again. And so the only way to precisely position the lens is really with infusion on. Turn on irrigation, and then you can manipulate the lens like I showed with the eye and handpiece. Sometimes you can use a second instrument like a cannula or a Lester hook or whatever. It doesn't really matter, but you can position that lens clockwise, counterclockwise. But as long as you have infusion, that means the bag is fully inflated and it's not making contact with the lens. And if it's not making contact with the lens, it won't cause any tractional forces on the lens. And you won't feel like you're turning the lens, but you're really not. You're just twisting and putting traction on the zonules in the capsular bag. In this way, I know I'm fully inflated. I have the lens properly oriented, and you can see this lens is perfectly placed at the 85-degree axis. Again, this is the Panoptix toric lens. You can see 360 degrees of excellent capsule overlap. And again, in this soft lens with a huge pupil, you saw excellent anatomy and how I execute the double chop and cross chop technique, placing the chopper around the rexus edge, hooking the lens from the lens equator, and then placing the fake tip on the other side, flanking the lens, and then being able to place the instruments deep, flanking the lens within the same horizontal plane, bringing the instruments together, fracturing the lens with mechanical forces, and then placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco-tip and fracturing the lens against the phaco-tip, and the phaco-tip is acting like a chopping block. That's the cross-chop maneuver. You can continue to repeat that maneuver and then fracturing the lens into smaller pieces. Again, with a soft lens, makes no sense to use any sculpting techniques because you're breaking up the pieces and then you can't crack those pieces. Much better to leverage mechanical fracturing in this soft lens, and again, a giant sized pupil. So I hope this was helpful to you, and I thank you for your attention.